Right, so I'm going to start with the changes that are going on here in 2014. Everything that touches healthcare reform is changing. We are seeing changes top to bottom, inside and out. The first thing is with government. Everything that touches government is changing. Every agency is all hands on deck, trying to write legislation, trying to write regulations that are helping to move the bill forward and clean everything up as we move into 2014. So the government is working as fast as they can, but they're having problems, as we've seen this fall, with where things are just not moving as smoothly as they would like. But they are definitely working on everything. I received an email today that they're expecting to they're working on 47 new regulations here for 2014 that they're presently working on. So lots of change still to come. The government is doing everything they can, from Health and Human Services to the IRS to the Treasury Department, to everybody that is touching it is making changes. We'll go around pricing flexibility. Prices, we are seeing actually prices narrowing. They're being on a great range. They're actually getting closer to one another. This is positive for some and negative for others, but we are definitely seeing a movement of prices more in an upward direction, but a little less flexibility there. Competition. Part of the idea of the healthcare bill was to increase competition. In Colorado specifically, as I'll talk about that most of today, the competition has not changed. We are seeing there's very little competition. There's very little competition in Colorado that's different than where it was. We're actually a pretty good state. We have 8 different carriers. There are some carriers that just have 1 or 2 carriers that are competitive in a market, and we actually have 8, which is positive. We have picked up we did pick up the Co-op, the Colorado Health Op, as a new carrier in Colorado. And we'll talk a little bit about them later, but they are a new addition. Otherwise, we have a lot of the same carriers. And the carriers have focused in different areas. We have some that have focused in northern Colorado, some in Denver, some in southern Colorado, some east, some west. And so there are just a couple of carriers that are competitive in any given market. But it does give us a couple different choices wherever we're at. But we are in a good spot that we have not lost carriers to. Providers are probably the hardest hit group in the whole conversation. Providers are the group that are concerned that their reimbursement is going to go down. They're going to have more work, more oversight for lower reimbursement, and that's a struggle. But definitely an issue for providers. And we're seeing that in staffing. For the first time in 9 years, we're actually seeing the jobs in healthcare decrease as compared to increase. And I think some of this will settle out as we move into 2014 and 2015, and providers feel more comfortable with how reimbursement is going to go. But in the scope of who is kind of winners and losers in healthcare reform, I would say that providers are the group that are going to be the hardest hit. They're the concern they're going to be the hardest hit, and have the most questions at this point. In a recent survey, and we've had the survey each of the last 3 years, they're asking doctors throughout the country how many doctors expect to be in business in 2018 practicing medicine. And for the last several years, that number has been consistent, that a third of the doctors currently practicing are expecting to be out of the business. And we understand some of that is retirement. Some are going to retire early. But a lot of them are just looking at it saying it is not as attractive anymore. They're having to work more and more hours to keep their income the same. The liability is high. They're having to pay high malpractice insurance costs, and it's just not what they were wanting to do when they got into medicine. So that's a group that has been the hardest hit. We expect that they will continue to be under pressure here. And my advice through all this is to encourage people to get to know your doctor well, and to if you have a choice, you're looking for a new doctor, I'd be looking for a doctor that's maybe a little younger than older, as we are seeing so many of the doctors that are closer to retirement age choosing to retire early. For consumers, we are seeing that consumers are struggling to find out any information. It's been very hard to find out any accurate information on the news and the newspaper, just because the bill is so large and has so much information that is coming through, that it's hard to find one place that it's all put together because it does touch so many different areas. So consumers are calling our office on a daily basis, asking lots of questions, not knowing what they need to do, where they need to go, and just looking to get coverage for their families. And it's been a struggle to get that information to as many people as need it. And then employers, that's a lot of who are on the call today, are struggling and concerned that things are changing and prices are going up, and how do you continue to take care of your employees and their families and offer an appropriate benefit as you have in the past, but also that it doesn't put the company out of business. So we're seeing employers do lots of different things. Most of our employers continue to offer coverage as they have in the past because they know that they've offered it for a reason, and they continue to see those reasons be the same, which is productivity and retention. At this point, where it is so much more difficult for individuals to get coverage and understand what their plans are, it is a benefit and a stronger benefit than it has in the past to be able to tell an employee that you do have health coverage that they do not have to worry about. So hopefully I'll be able to address a lot of the questions and concerns here for your employers and help you feel a little more comfortable at least about what's going on so we can move you in a positive direction. So the next slide is just a list of some of the things that have changed, and this list continues to be added to on a regular basis. I'm just going to point out a couple of these. If you see any of these that you want more information on, let me know, and I can definitely talk through those here today. One of them I'll point out is anybody who has a flexible spending account, the limit on those accounts has been cut in half. So it was a $5,000 maximum contribution for the family per year, and that's been cut in half down to $2,500. A question I get from a lot of employers is they hear about the W-2 reporting, and the requirement says anybody who has health insurance for their employees and has more than 250 W-2s printed for the year, that they have to put the cost of the benefits from the employee and the employer on the W-2. So most of our small groups are exempt from that, so you don't have to worry about that. So if you have those less than 250 W-2s, that you're exempt from that, you don't have to worry about it. Some of the things we're seeing here in 2014, we are seeing the ICD-10, that's the new coding system that's been delayed here into October, but that looks like that will implement. Any providers are definitely aware of this, and it is on their radar screen as a big issue to changing all their coding and how they interact and what codes they put on things. So, and it'll also adjust their reimbursement. I got a question on health reimbursement arrangements. So a new piece of legislation came out, and we just don't have it listed here, that effective January 1st, 2014, you can no longer use an HRA to reimburse for individual premiums. Last year in February, I actually sat down and talked to the gentleman who wrote this legislation, and he put things out in January of last year, came back and re-clarified some things here this fall. But the basic intention is that the federal government is not going to allow an employer to move pre-tax dollars to an employee to pay for an individual premium. So it's been allowed in the past. There's been some questions in Colorado on that. But moving forward, it's very clear from a federal level that we cannot use an HRA to do that. We have some companies that have used a Section 125 to do that, so that is not allowed as well, to allow pre-tax dollars to move to the employee. If an employer wants to reimburse for an individual's premium, they just need to put dollars into their gross income, and then everybody pays taxes on those. The second part of that is for health reimbursement arrangements that are through a company. So an employer, you have an employer-sponsored health insurance plan, and you use an HRA for the employer to move dollars to the employees to help pay for expenses. Those are still allowed as long as they're tied to a group plan. So that's what the legislation really does. It ties into the employer-sponsored plan for an HRA. And there are some limits on that, and if you have that plan design, call me. And if you want to talk about that more, we can talk about HRAs, how they work, and the positives and negatives of those. The basic idea is it allows an employer to help pay claims that an employee with pre-tax dollars. The last thing I'll throw out here, and we'll talk about this in a little bit more detail, the waiting period for new employees will be changing as well. Currently, we can pick kind of any number the legislation has moved that to a 90 days from the date of hire. So what that practically means for all of our employers is that as we renew here in 2014, your waiting period will have to go to 60 days, because an employee, if they're hired today, January 16th, 90 days would put them middle of March. If we have a 90-day waiting period, it's the first of the month following that, and that's over 90 days. So as we renew everybody, we'll move them to the first of the month following 60 days or less. And also the requirement for hours worked will decrease. Currently, we can do anywhere from 24 to 40 hours, and now that number will be between 24 and 30 hours. So 30 hours is classified as full-time, and that may impact some of our groups. This is just showing that things are changing. They continue to change on a regular basis. Every couple days, we're getting a new piece of legislation coming out of Washington changing how plans are operating, how the exchanges are working. Something significant is happening. And so that's been going on for a year and a half for us. And so we continue to be on top of that. If you have questions, concerns, call us. If you hear anything on the news, feel free to call us on those as well. Just saying, what is this? I'm concerned. Something doesn't sound right. Is this going to affect me? Feel free to let us know, and I can talk through those with you. Now we're going to move to the benefit changes as we move into 2014. So the landscape of how plans come together is going to change. So the first thing is we have these essential health benefits. So all individual and small group plans have essential health benefits, which are a list of 10 different things in plans. Currently, we have most all of these covered on all of our plans. As we go through the emergency room hospitals, all of those things. In Colorado, we are one of the few states that already required for individual and small groups that maternity is required. And that has helped stabilize our rates a little bit over other states who had to add this here in 2014. So that is a positive for us in Colorado. The next thing that's been impacted is prescription drug coverage. The legislation requires that all plans cover prescription drugs in at least 2 drugs in each category. So what we've seen here is we've got some plans that do not cover prescription drug coverage. They are now having to cover prescription drugs. We've got a lot of plans that were covering generic-only drug coverage, and now they're going to have to pick up the brand-name drug coverage. So we will. So we're going to see as our plans in 2014 will be adding those type of benefits to the plans. Also, what we're seeing in 2014 is carriers are starting to limit the amount of drugs they're covering. So since they only have to cover 2, all of the carriers are starting to limit down their drug plans, so they're not going to offer as many plans as were previously available. So we may see some of our members that are going to have to change to plans that are changed prescriptions that they currently have to plans or to prescriptions their plan does cover, or we may have to look for plans that cover their specific prescription. So that is a change that we're seeing a little more than we anticipated. Habilitative and rehabilitative care. So rehabilitative care, that's physical therapy. We've seen that. We understand what that is. Just going to get a physical therapist for something that we have injured ourselves that we are getting back to where we were. Habilitative care is a new introduction that a small group and individual plans are required to cover habilitative care. And habilitative care is for somebody who wasn't well to start with to get them there. An example of this is speech therapy. So a child who's 2, 3 years old isn't talking at an appropriate level, so they go to speech therapy to get them on track to where they need to be so they can move forward in life from there and not be behind. So that is a new introduction that was not covered on previous plans and that specific requirement. Preventative care, this has kind of been phased in over the last couple of years, but preventative care is covered on all plans. And preventative care is anything that is a wellness exam, and it needs to be billed as wellness. So for an individual, that'd be our annual exam. For kids, that's their annual exam plus immunizations, the required immunizations for kids. For adults, for males, that would include eventually prostate exams and colonoscopies, females, mammograms, PAPs, well woman exam plus physical, and then eventually colonoscopies as well. So one place we get a lot of questions common issue we run into that providers are billing colonoscopies in two different ways. They can bill as wellness if everything's clean, everything is normal, everything went well, and then that is covered 100% under that benefit. If they bill the colonoscopy as a diagnostic procedure, and the tricky thing here is you don't know till you're done if it's wellness or diagnostic. If they bill it as diagnostic, then you pay it all towards your deductible, and this can be a $1,500 bill. We see those from $800 up to a couple $1,000, depending on exactly what they had to do. But a lot of times they don't know until they're in there what they need to do and how they need to address it, and they just take care of everything while they're in there. So that's one where we just encourage people continue to communicate to your provider that it is wellness. And then our last service is for pediatric services. This has become a very large issue here the last couple of months, even though it's kind of a small piece of the whole puzzle. So all plans are required to cover pediatric dental and vision coverage. Pretty much all the plans have built the vision coverage into their plans, but because of some carrier feedback and kickback here in Colorado with standalone plans, some carriers have pulled the pediatric dental coverage off of their plans. Through the exchange, it's optional, so you'd have to add it through there, and then on group plans as well. So as our plans are renewing here in 2014, some of our carriers like Kaiser and United have included the pediatric dental in their plans. Anthem has not, so that has to be added. And it's not a huge charge, but it has to be added onto the policy. And that includes all adults. So as adults, even if we don't have any kids on the plan, we still have to have this piece to have a compliant plan. So we pick up a plan anywhere from a $0 charge to a $1.50 a month charge. So those are the requirement, but that's some steps that we have to go through. And a lot of people are asking why they need to do that because they don't have kids, and it's just a requirement, and it's just the way it is. And so we'll help deal with everybody deal with that at renewal to make sure that you have the appropriate coverage and that we don't have to worry about any concerns there. Also, as a note on that, the only carrier that has for dental plans that are compliant with pediatric dental, Delta Dental has a couple of plans that are, and that is the only carrier that are currently compliant. The rest of the carriers are working on that. They all had assumed that the carriers would include the pediatric dental in their coverage. And pediatric dental is different as compared to a normal dental plan in that it has one sticky requirement. It has to cover medically necessary orthodontia for kids. And the only medically necessary orthodontia is not if the orthodontist says you need the coverage, but if somebody has a cleft palate. And currently dental plans do not have that provision, so they're having to rework all of those to add that to it. As we move into 2014, you're going to see here that we have two different options. We have on-exchange plans and we have off-exchange plans. So this is for individual and small group. I'll tell you that for individuals, we are talking through everybody with them, and it's all income-based. So we talk through and make sure we find the right solution for them. And then for groups, most of our groups are going through off-exchange. We have very few that are going to be on-exchange just because there's not a lot of benefit to being on the exchange. Currently in the Colorado exchange, you have a couple of carriers there. You have a couple of noted carriers that are missing. United Healthcare is missing, Cigna is missing, Humana is missing. Anthem is there, but they have just 3 plans in their HMOs. So that's the kind of what's going on there. We have some other smaller carriers that are in there along with Kaiser that give you some options to choose. You'd go to the exchange as a small group for 2 reasons. First, you'd go if you wanted the small group tax credit. You can claim the tax credit for 2 years, and there's a formula for that. And I can help you figure that out because it does vary based upon the income of your average employee and the number of employees you actually have. And then we're doing most of our individual plans off exchange as we have in the past, where we come in, look at plans, choose plans, and enroll them as we always have. So that process really hasn't changed. For individuals, it has changed because based upon the individual's income, we look at it and determine are they going to qualify for a subsidy. If they are, then we're going to help set them up through the exchange and move them through that process. And if they are not going to qualify for a subsidy, we just go directly to the carriers we have in the past because it's a much quicker, smoother process to do that. As far as the pediatric dental piece on and off the exchange, for any plans that are sold, for individual plans sold off the exchange, they have to include the pediatric dental in the plan. If they're on the exchange, because you have the choice to choose your own dental plan, they are excluded, so you have to add that as you go through and sign up. And then for the groups, it varies based upon the carrier, how they're handling that. I mentioned here before, just the other thing is the maternity. We already have maternity coverage in Colorado, which has been very positive. So now we're going to move into the plan designs, how they work, what's different about them. The first thing we'll talk about is out-of-pocket maximum. So this has changed and changed right before the 2014. So we didn't update this, and I did this intentionally because I wanted to show everybody that things are changing. It's very fluid. Things are changing very fast, and so we just left everything the same. The maximum out-of-pocket for an individual is $6,350 is for any 2014 plans. For a family, it's $12,700. Now, how we accumulate this number is different than all the current policies that we've had prior to 2014. So it has generally been your deductible plus your coinsurance. That's your 20 or 30% that you pay. Those two numbers combined work towards your maximum out of pocket. If you satisfy that, then everything's covered, with the exception of copays, like copays for prescriptions, copays at the doctor, emergency room. You would still pay those the entire way. As we move into 2014, that changes. All of those copays add up towards that maximum out of pocket in addition to the deductible and coinsurance. They all go into one bucket. And if that bucket gets full, you hit that $6,350. Everything for the rest of the year is covered at 100%. So with this change, this is positive for consumers because it's a true maximum out of pocket. You work towards that. You know what your max number is. You hit that number, and then you're done. It's a little easier to work with than the plans in the past. We always wondered why we continue to get bills. The downside to that is that one provision is a 7% increase in rates. So positive and negative trade-off there. But that has been well received. We haven't had a lot of negative kickback from that, which is nice. The small group deductible ceiling, I'll tell you that this in Colorado was waived. They originally said just for the small group market, the highest deductible you can have is a $2,000 deductible. But they gave the states the option if you feel that you cannot, and carriers the option if you feel you cannot design plans specifically in the bronze level that have a $2,000 deductible, then design plans that have a higher than a $2,000 deductible, and the state can elect on a state-by-state basis if they're going to allow that. Colorado did allow that, so we have deductibles that are similar to what we have in the past. So $5,000 deductibles are allowed, and then $2,000, $3,000, $4,000 deductibles as well. We see a lot of those in and out of the exchange. That's another piece that Colorado decided to allow that, and that was a change here in the last couple of months, which was positive and has been well received and has helped us lower rates and keep our rates a little more manageable. Now I want to talk about the metallic plans. So plans as we move into 2014 all have to fall into a certain window. So this graph will kind of show how they fall into this window. So they are based upon actuarial value. You don't necessarily remember this, but I'll explain what it is. So actuarial value is a new term and a new way of figuring things. It says on average, if you're kind of in the pool of the insurance carrier as a whole, plan X, whatever plan it is, how much of the cost overall will be paid by the individual, so the person seeking care, and by the insurance company. So what is that ratio? So a platinum plan, so the richest plans, that's a 90-10 split. And it's not just a straight 90-10 split. It's split through copays, deductibles, coinsurances. So the platinum plan is the richest plan. So that's a 90-10 split. A gold plan is an 80-20 split overall. Silver 70-30, bronze is 60-40. Now, we have to have a plan that is within 2 percentage points of that. So they have that Health and Human Services has designed that you put your information in through, and it works its way through the formula, and it tells you what the actuarial value is. And so that will probably change over time. So right now, the most popular plan in Colorado is a $5,000 deductible HSA plan. It's a great plan, very popular plan. Several carriers have that same plan design, and it comes in actuarially valued about a 65. Because it's not in the 60 range or the 70 range, that plan is not allowed. So everybody who has that $5,000 deductible HSA will have to change plan designs as we come into 2014 unless they're grandfathered, which means they can keep it. So they'll have to move to a different plan. Similar plan, and we're seeing some higher deductibles and lower deductibles to get them either into the silver or bronze level, but just we'll have to make some of those changes. Over time, as plans change and actuarial values change, we may see that every year that people have to change plans to slightly different plans to continue to stay in the right windows as they continue to work on the actuarial values and move around those calculators. So that can be frustrating as we move forward. Hopefully that allows everything to stabilize so we don't have to do that every year, but that's a concern is if they tweak it that all plans may be tweaked and we have to every year make changes. So when we start talking about plans, as we start talking about plan designs at renewals, you're going to see that they'll all be labeled bronze, silver, gold, and platinum. So those are just a new way of looking at things, but the plans will look similar to what we have now. So this is just a graph. I'm not going to go over it in a lot of detail, which just kind of says what applies to different groups. Small groups are subject to the essential health benefits. Large groups are not. They just have to meet a minimum actuarial value, which is different than the essential health benefits. But at the end of the day, a lot of the plans will look very similar to what we do now, and self-funded plans are exempt from that as well. Self-funded plans, I think we're going to see more employers looking at self-funded plans because they not only allow you to have some flexibility in the plan design so you're not stuck into the windows, but also they're going to allow you to avoid some taxes that we'll talk about here in a minute that can lower what you have to use as a starting point for those plans, which can be helpful and definitely be a conversation for a lot of our groups, especially those that are 20 or more employees. The out-of-pocket max, we talked about that. The deductible, that's been waived, the metallic plans, and then pre-existing conditions. All pre-existing conditions have gone away. So any plan that is written in 2014, moving forward, so if a plan renews, let's say in March, at this point, no pre-existing conditions apply. If you have a plan that renews in November, if you have a new employee that comes on today, they will still have the pre-existing condition clause if they have not had prior coverage. Same thing in the individual market. Anybody who comes onto an existing plan will not be able to will still be subject to underwriting. So we're seeing most of those move towards 2014 plans anyway and not allow people to come on to those individual plans, not company, but individual plans where they're still underwriting. As we move into the waiting periods, employer mandates, we'll talk about the employer mandate here in just a minute. The waiting period, as I mentioned before, it'll go to 60 days as the maximum waiting period, so first of the month following 60 days, and then a 30-hour wait. All plans are going to be guaranteed issue, so as long as the company is a true company and the employee is a true employee, they're going to be issued. There's going to be no underwriting. They're also not going to adjust rates based upon the employer's occupation. Right now there's flexibility on the SIC code, and things will move up and down. And then women's health preventative services, there's some additional services for women that apply that came into play in 2012 that have been positive. The most utilized is definitely that women who are on birth control, if they are on certain levels of birth control, meaning like generic levels of birth control, and there are certain categories there that they can get the birth control at no cost. So those will come through with no copay. If somebody's paying for that, I just encourage them to talk to your doctor, see if they have an option that could be at no cost to them. And it may or may not be the right solution for them, so that's why talk to the doctor and see if that's appropriate. Also in the women's preventive health, you see there's some different counseling services that are there that are positive and needed. Some contraceptive services, including some over-the-counter contraceptives for women, not for men. Breastfeeding supplies and breastfeeding pumps are covered, and then also tubules are covered. This has always created some strange looks and rolling of eyes from our doctors, because most all doctors will tell you if a couple is done having kids that it is the best interest for the husband to get fixed, to do a vasectomy. It's much less invasive, simple procedure. Guys tend to not like it as much, but it is just what it is. That's the better way to go medically. They encourage that. And then, but they cover tubules at no cost. You do a vasectomy, if you had to pay for it towards your deductible, it's like a $1,000 procedure the last time I checked. So now the health bill gives the woman the opportunity to get a tubule done at no cost, but pay for the vasectomy, which is less invasive. So the doctor's like, this doesn't make sense. It moves us in the wrong direction. But that is covered, and just trying to specifically address some things for women and women's health. The employer mandate. So this is going to apply for groups with 50 or more full-time equivalent employees. So I'm going to talk through this for the next couple of minutes. A lot of our small groups are going to be exempt from this. But I'll just kind of explain what it is as companies grow. They know that 50 is a key number. So full-time equivalent employees is basically you take all your full-time employees and then you take your part-time employees and add them up. So let's say you're a restaurant. You have a whole bunch of employees that work 15 or 20 hours a week. You would add all of their hours up, divide them by 30, and that number will tell you how many full-time employees that you have, full-time equivalent employees. So you could have 100 employees running around at a restaurant, 10 are full-time, and then all these part-timers combined together to give you more employees than the 50, and all of a sudden you're required to offer health coverage to those that are working full-time. So then you'd be coming back and just your full-time employees. You do not have to offer it to the full-time equivalent employees, the part-time employees. You don't have to offer it to them. You just have to offer it to the full-time employees. So with this, if you offer coverage, if you're offering coverage to those full-time employees, you're fine as long as it's affordable. We'll talk about affordable here in just a moment. Then you're fine. You have no issues with penalties. If you do not offer coverage to those employees, then we look at a couple different things. First, you're subject to a penalty if you do not. If you have those 50 full-time equivalent employees, you're subject to a $2,000 per year penalty for those full-time employees, minus the first 30 employees. So if you have 100 employees, they're all full-time, and you don't offer coverage, you would pay a $2,000 penalty for the year times 70 employees. If you have 100 employees, but most of them are part-time, you could be in a situation where you have 10 full-time employees, and because the first 30 are exempt, you actually have to offer coverage, but there's no penalty if you don't because you fall into that window. Just know that we'll help talk through that with you because it'll vary based upon what's going on in your specific company. And there's some measurement periods that we work with to determine if you have employees moving around, you're close to 50, can we measure it to tell us if we are 50 above or below, and how we do that ongoing. If you're close to that, call me. It's a longer conversation. It's really a 3-hour presentation that we're not going to go through today, but just know that that exists. Business owners are smart, so they'll come up with good ideas, and they say, well, we have a company, let's break it into 2 companies or 3 companies, and then we'll all have companies under 50 employees and just not offer coverage in any of them. And that works as long as you have different ownership. If you have common ownership between those companies, so if one person still owns all 3 companies, they actually aggregate together and they're counted as one company, and then we look at the penalties as if they're one company. And it follows the IRS's rules for the aggregation there. And this applies to both fully insured and self-funded groups as well. And this applies to grandfathered plans as well. So if a large company has a grandfathered plan, they can, they're exempt from certain things, but they do have to offer coverage to all the full-time employees. As part of this, you do have to offer coverage to all dependents up to age 26, but you do not have to offer coverage to the spouses. So there has been some debate for employers, large and small, should you offer coverage to spouses? If you do not offer coverage to spouses, then they are eligible to go to the exchange and to claim a subsidy. But if you do offer coverage to the spouse, then they do not have the opportunity to go to the exchange and claim a subsidy. So with that, there are some employers who are saying, well, we want to drop spouse coverage. The problem there is if you have a key employee, and generally the owners, they'll have their whole families on the coverage, it would exempt all of those spouses as well. So at this point, we have not had, in our company here, we have not had a single group we work with drop spouse coverage. It just seemed to not make sense to the employers just for a lot of reasons to drop the spouse coverage. And so all those changes are effective in 2014. So then we're going to talk about affordable coverage. Is coverage affordable? If a coverage is deemed affordable, then an employee that's being offered to them by the employer, then the employee cannot go to the exchange, nor their family go to the exchange. So the test for this is 9.5% of the employee's gross income. So the box 2 or W-2 box 1 income. So it's a gross income. So if an employee, we figure their number. Let's say they're making $30,000 a year. So we figure that through, and it's 9.5% of their income. That's how much they can pay in the employee-only premium, so their portion, and then it is deemed affordable. So if the employer, let's say you're splitting up premium 50-50 of this employee, and their portion is, say it's a $300 premium, so their portion is $150, even though they may say that's a lot of money, they cannot. That's deemed affordable by the definition, so that they cannot go to the exchange and get a subsidy. As a kind of a snag in the health bill, it also said if an employee is offered coverage through their employer that is deemed affordable, their entire family cannot go to the exchange to get that subsidy. So that's been a tricky conversation, because we'll have a company that will come out and say, hey, we've got an employee. We're going to pay 100% of the employee-only premium to take care of them. And they're not the highest paid employee, but we're going to do that to be generous to them. And then they can cover spouse and kids on their own. So the employee is taken care of 100%, but the spouse and kids, they're actually having to pay more than the 9.5%, because they can add them to the group plan or go in the individual market where premiums are very similar priced and have to pay the full premium. We've heard from Washington that there is some talk that they want to address this, because it doesn't seem appropriate that if an employee is at that 9.5%, they have to pay all of their spouse and kids and get sometimes in the 20 and 30% range of their income to pay for that health insurance, and just not having access to any subsidy help. Right now, there's no specific legislation to address that, but I know that'll be a topic here as we go through 2014. So that's for determines affordability. And then for large groups, there's this minimum value that says that kind of like the metallic plans, where they tier those out. For large group, they just say, here's a floor. You have to offer at least one plan that is a 60% minimum value plan. So you can offer one plan that's 62 or 70 or 80, and then you can offer plans below that as well that do not qualify. They're not at the 60. They're below the bronze level type of plans for a small group. So very bare bones plans. So we do have some very large employers that have taken advantage of this. So they have a very rich plan that their lower compensated employees just simply can't afford, and puts them 70, 80, 90% range, but then they come up with a very low plan that's kind of the old mini-med ideas, where they say, we'll give you a health plan, but it only covers a maximum of $10,000 or $25,000 in benefits. So if you have a $100,000 procedure, you're going to pay for most of it. And then the last thing I'll throw out here is, if an employer offers a plan that is deemed not affordable, so this is large group deemed not affordable, there is a $3,000 penalty. So if you offer a plan and you have an employee and they have to pay $500 a month for that plan, and that's above their 9.5%, the employer is subject to a $3,000 penalty. So what we're seeing with a lot of our groups that are in that category, that are a large group, they're looking at it saying, oh, this person is at 10.5%. It actually makes more sense for them to come back and to bring them down into that 9.5% for the employee only, to make sure that they're in the right spot, so they don't have to worry about the $3,000 penalty for that employee for the year. We're going to see, I think we're going to see some changes with this as we move forward. The employer mandate has been delayed till 2015 for the 50 and older groups, so that's our 50 and higher group numbers, so that's been helpful for those groups. But I think we're going to see that some of this is going to be surprising to a lot of our employees and how all that works. I'm not going to go over this grid in too much detail, but this kind of shows you those that are close to the 50, how where they move, do they pay penalties, do they not pay penalties, and how all where they're subject there. So you can ask me questions on that, and we can talk at greater detail. Now we're going to move to the individual mandate. So as part of the health bill, anyone who has anyone in the country everyone in the country is required to purchase health coverage, or they are subject to a penalty on an individual basis. So you can get coverage in many different places, whether it's through the employer, on your own, as an individual, through the exchanges, Medicaid, VA benefits, Medicare, and there are a lot of different places where people can be covered. As long as you have coverage, you're fine. If you do not have coverage, starting in 2014, the penalty is the greater of either $95 an adult, or half of that for kids. So for a family, it'd be 2 adults plus your 2 kids, you'd add those numbers up, or 1% of the family income, whatever is greater. In 2015, those numbers go up to $325 for an individual, half of that for the kids, or 2% of the family income. In 2016, it's $695, or 2.5% of the income. At this point, we're anticipating that more people will actually run into that 1%, 2%, 2.5% number than the actual $95 type of round numbers. At $95, if the ratio works for that to be 1% of their income or less, so the $95 would be their number, they actually would qualify for Medicaid. So they would just simply need to go on, sign up for Medicaid, and then they would avoid the penalty. Now, there are a couple of entertaining things about the health bill that maybe it's because I spend too much time with the health bill studying it that become entertaining to me. So the first of these is these penalties would come through on your tax return. So when we all file our 2014 tax return, we'll have to show that we have health insurance. We'll put our information there and that we had it for the required amount of time. If we do not, the penalty will come through on our taxes, and we'll owe that penalty. Now, there's no, usually with the IRS, if you don't pay your taxes, they've got a big stick. They can garnish your wages. They can do everything, and they can come and get that money. Well, with this, they cannot come and get these penalty numbers, just the way it's classified and how the Supreme Court ruled on that. So if somebody owes their taxes and they say, well, I'm not going to pay this penalty to the government for not having health insurance, there's nothing the government can do at this point. So that number can accumulate over time, and at any point if they have a tax return, that number will come out of there and the return will be less the dollars that are owed. But if somebody wanted to avoid the penalty, I'm not endorsing this, but if somebody wanted to, they could simply just make sure they owe on their taxes every year and not pay that penalty. At some point, that penalty, if they have a refund, that penalty, those penalties are there, they'll be claimed. But that is an option out there. I don't encourage it, but it is definitely a way to work the system for those that are not happy with what's going on. So we're going to move now to pricing, how the plans are rated. Currently, in Colorado, in our small group market, we can rate on a couple different things. We can rate on a geographic area. We currently have 9 geographic areas in Colorado for most carriers. We can rate on age. So we do 5-year rate blocks for our age banded. For composite, we just average those all to 1. And those 5-year rate blocks will move up, and there's a ratio between the least expensive 19-year-old and the most expensive 64-year-old of a 5-to-1 ratio. And then we can rate, a couple of carriers are rated on tobacco use, and we can rate on industry. We cannot rate on any type of health underwriting for the groups. That went away in Colorado, which has been helpful to us to allow our rates to be a little more stable as we move into 2014. Other states are having to make all their plans guaranteed issues, so just more changes that they to all kind of come at once for them. As you move into 2014, this changes. Some of these things change. We can still rate on a geographic area. There are now 11 areas in the state that really doesn't affect most of our clients, just where the new areas are. The age spread is now a 3-to-1 ratio. So the 19-year-old and the 64-year-old can be a 3-to-1 difference compared to 5. It was previously, if a 19-year-old was $100, you can charge a 64-year-old $500. Now, what we're seeing is you charge that 19-year-old $150 and that 64-year-old $450. Well, we're seeing a couple things with this. First, the older end of the population, not picking on anybody here, but that's where most of our claims are. So the carriers, even in an ideal world, if everybody enrolled, you'd be able to bring those to the middle. But with our older population being those that are enrolling at a higher rate and those with higher claims, we're actually seeing that move upward. Well, we're seeing this impact on rates as well, where we're sitting down and sat down with a client yesterday that the older group of their company, the older couple employees, their rates were increasing just by a couple of dollars. Their younger employees were increasing significantly, and that's due to that the age band spread there condensing down closer to the middle. So that's an impact that we'll continue to see. And the last thing we can rate on in Colorado is tobacco use. Currently, a couple of carriers are rating as high as 15%. The health bill allows for an increase of up to 50%, 50%, which is a lot. In Colorado, they came out with a piece of legislation seeing that and being concerned about it, and said we can only do 15% in Colorado. The real cost of that, by the way, of smokers is closer to about 47%. All the carriers that we've talked to over the last couple of years, they would rather not rate for tobacco. They would rather have the individual stop using tobacco. That actually works better in their numbers. It works better for everybody. So that's where their head is. For a carrier to implement the tobacco load, they have to offer a smoking cessation program to the individual. So if they come in and say, we're going to put a 10% or 15% increase on the premium for this individual, that individual has the option with that carrier to enroll in a smoking cessation program, and simply for enrolling, they can have their increased premium for the tobacco use removed, simply for enrolling. And so if you enroll, that's how you reduce those numbers. The carriers are, again, looking to just get people to stop using tobacco. That's where everything works the best. So that is the tobacco load. That's why the only health question we ask for anybody now is if you are using tobacco, and then they can rate on there. Now, the definition of tobacco use, this is probably the most entertaining thing with the health bill. The definition of tobacco use has changed. Currently, it has always been if you've used tobacco in the last 12 months, then you are considered a tobacco user. Now, that has changed and says if you have used tobacco on average over the last 6 months, 4 or more days a week, you're a tobacco user. But you could exclude the days that you use tobacco for religious ceremonies and other rituals. So that is one that's always drawn lots of laugh and entertainment from the crowd because they look at it and say, well, that's interesting, especially in Colorado with the new marijuana law that has passed. So with that, I can tell you that most of our tobacco users have told us at this point that they no longer fit the definition of tobacco use, which is very interesting. But the smoking cessation program is still there for those that do want to quit. For the carriers, they definitely want to help people to do so. All right, so this graph is just showing that there's a wide range of costs between states, between plans and ages, and with this, we are seeing that things are condensing down to the middle. For the carriers or for the companies, based upon your industry, there was a large spread of about 35%. That's all in one spot. Their age bands are getting smaller, so all of our rates are getting closer to the middle. There's still a spread between those, but they're definitely getting closer to the middle than where they have been in the past. Rates. So we always get a question about rates. That's obviously the end concern is how does this impact us? So I'll talk through the three markets: individual, small group, large group. So currently in the individual market, we've been seeing increases the last 2 years of roughly 12%. As people, that's for the kind of the trend of the plan. You will see that as people are aging up each year, they get a year older, and the rate adjusts for that as well. So we can see some a little higher, but that's about the trend we've been seeing. As we move into 2014. There's one major provision that has had an impact here, and that was the guaranteed issue. Simply by taking a plan and making it guaranteed issue, we're almost doubling the rates just for that one provision. Then with that, there's some taxes we'll talk about in a minute here that are on the conservative side, about 3.8%. Some estimates are as high as 5%. And then just the product changes and some of what we've highlighted here so far. So with those changes, we're seeing increases. They would be trending about 100%. In Colorado, we're trending because we had a couple of the provisions in the health bill already. As far as the maternity was already included, and a couple other pieces in there. So with that, and then the carriers are also have come out with HMO plans in the individual market. So the HMO plans are narrowing networks, so all of the plans on the exchange, off the exchange, by and large, are those HMOs. We have a couple of PPO carriers out there as well, but they're narrowing their networks. And by narrowing their networks, they control some costs by excluding some higher cost providers and higher cost hospitals as well. So you're seeing that that is across the board, and that's been a big change. It has been a shock to a lot of the consumers that we've talked to. But we're seeing on average about a 70% increase from from the 2013 rates, which has been a big hit. The small group market, we're seeing a wide range of increases here. It depends on the age of the group. The older the group, the lower the increase. The younger the group, the higher their increase. Also on plan designs, some of those that had generic-only drug plans, we're seeing as they pick up the brand name drug coverage, some increases there. So we're seeing a spread here, anywhere from companies getting single-digit increases, which has been very positive, up to we've had a couple that are closer to 100%. On average, the bulk of our clients are sitting between 25 and 35% as far as increases here in 2014, and we continue to work with those clients to make sure we're finding the right solutions moving forward, whether it's changing carriers, plan designs, to get everybody to the right spot. Then, because that's a tricky place for the company, because we want to continue to provide benefits for those employees, and we got to make it affordable on both sides. Large groups, we're not seeing quite the impact in a large group. We're seeing increases closer to 20%. I'd probably say the numbers we've seen are closer to 18%, which is a high number, but they can still take health into account with large groups, because a lot of those groups are still self-funded or partially self-funded, and then the carriers also take claims experience into those groups. So just the provisions of the health bill come into play at the 20% range, maybe a little better. So those are kind of the rate increases, and all those plans the rates are getting closer. So it used to be that a company plan, if they had a plan, let's say it was $300, for example, that same individual should be able to go to get an individual plan for almost half of that. Now, as the rates have increased and changed, those two numbers are very close. They're closer to about a 10 to 15% spread now. So if an employee has a plan, even if they had to pay the whole cost and they run it through their employer, simply because you can run those benefits through on a tax-free basis, you save about 25% on average on those plan designs, or on those premiums. And so that actually puts you below the cost to the individual if they had to pay with their after-tax dollars for that individual plan. So we're seeing a movement for not only employees coming onto group plans. We've seen over the last 30 days a huge movement towards more employees coming onto the plans, but also more dependents coming on the plans. As we look at spouse and kids, all of a sudden how they're figured are all coming onto the plans, just because it's making more sense based upon exactly what they have going on. So those are some of the trends we're seeing, which is the opposite of where we've been before, whereas mainly just the employees that were on group plans. So here are some of the changes that we have coming through in 2014, just kind of highlighted for small and large groups, just so we've got them all in one place. And so let me know if you have any questions on that. And then as we get into the taxes, there are a couple different components of taxes. First, there's this risk program, I'll just mention it, that you're going to have a couple of small taxes that come through because the federal government is basically they're collecting dollars for a couple of things here, and the main one is they're collecting some dollars so that if one insurance company has more claims than they expected compared to somebody else, that there's some dollars to help keep them afloat so they don't go out of business because they price things incorrectly the first year or two here. It's been hard for the carriers to find correct prices just because there are so many variables that it's been tough for them to narrow down exactly what their risk is. I was talking to one carrier in their leadership, and they said that there were certain provisions that are going around the table. They had their top people in the company together there. There are about 8 of them, and they were saying, how do you think this will impact the rates? How do you think this will? And they were all just taking their guesses, averaging those guesses, and that's what they're going with for their rates, because that's literally the best information they could provide, because there's so many variables that their traditional actuarial numbers just were not helpful to them. So those are just some of the changes that we're seeing. So you'll see some small taxes there. So coming to the next page here, the large tax you're going to see is the insurer fee. The rest of them are fairly small in the scope of what we're doing. But the insurer fee comes in, and it starts here at an $8 billion tax. And so this is the majority of that 3.8 to 5% that's coming onto all of our plans. So it starts at $8 billion, but this number starts to ratchet up, and it'll be out to over $14 billion, so almost double by 2018. So this number is going to continue to increase over time, and there's no governor on it after that. So this is the spot if the federal government feels they need to get more dollars for exchanges or other purposes to make the health bill balance, this is likely where they are going to adjust that, where they'll bring this number up. There is a bill that has continued to float around the last 18 months in the House and Senate at the federal level to remove this. They call it the Stop the Hit bill, because they're saying that it's going to be a big hit to individuals, because the carriers are just passing this on to the insureds because they don't just have money sitting around. It's flowing through, and so as a cost to the policy to them. So, and with this, for anybody who on the individual side specifically, if they get an individual premium, if they have to pay these higher premiums, and they're subsidized, the federal government is, in essence, paying this tax to themselves, which is kind of an odd thing to think of. That's why they've kind of said, why are we having this if a large portion of the policies that are in the market are subsidized, or a portion of them are subsidized, and a large portion of the subsidy is just paying the tax on the plan. So that's been the debate on the plan, on this specific tax, and they're really trying to push premiums downward is what they're trying to do here by eliminating that. Exchanges. So I'm going to spend some time on exchanges, and specifically the Colorado exchange, but I'll kind of talk about all of them here a little bit. So the history of the exchanges are that all the states had the option to elect an exchange if they would like, to do it on their own, or to have the federal government run them. And kind of the exact opposite of what we expected from a political standpoint, the exchanges came about. So the states that embraced the exchange, and Colorado is one of them, and I'm very happy that they did, and I think it's very positive. They tend to be more of the more democratic-leaning states. The conservative states all decided they were not going to comply with the health bill, so they let the federal government run their exchange, and it's generally a little more backwards from where we generally expect those to be. For example, in Colorado, the exchange got passed because at the time the Senate Majority Leader, who was a Democrat, proposed the exchange bill, a very conservative bill, and said we don't want to be run by the federal government and then telling us what to do. We want to be able to be in charge of this and have input in what's going on in our state. So she proposed this, and it was a very close House to Senate number as far as who had what majority there. So she proposed it, and the Republicans all opposed the bill because they're saying we don't want to comply with the health bill in any way. Well, the Democrats decided that they wanted to support the health bill in this. They took this conservative piece of legislation. All the Democrats voted for it with 2 Republican votes, and it passed. It goes to the House, where the Democrats controlled the majority. They passed the bill on party lines, sent it to the governor, who's a Democrat, and they passed it. So you take this conservative bill that was designed by Republicans, and the Democrats passed it. And the political people we have in Denver were banging their head against the wall, just saying, I have no idea what's going on in this world anymore, because of how that came about. So we have our own Connect for Health site here. So it's Connect for Health Colorado, and the website's www.connectforhealthco.com. And then 33 states are all run by the federal government on their healthcare.gov site. And the healthcare.gov site has had lots of issues. Probably heard about that in the news where it was not working. Colorado has been better throughout the process. The major snag that we've run into on our individual side is that the application process has a very large Medicaid application. And most of the states, the questions are short and simple, and they're basically looking for where you are in relation to poverty level to see if you qualify for a subsidy. In Colorado, the Medicaid office did not want to limit their current application, which is 27 pages long, and gathering information. So even though they're only pulling data from one line in the entire application, everyone who wants to apply for a subsidy must first be declined for Medicaid, so they have to complete that 27-page application. Just say that the Exchange Board and the governor and everybody else involved, top to bottom, are very aware of this issue, and Medicaid has promised that they will fix the application as we move into 2015 open enrollment. So that's the exchanges. In Colorado, mainly what we do use the exchange for is for the individual side of things. The small group does have that exchange if you want the tax credit. The other option you have with this small group exchange is to offer multiple plans. So if a small carrier wants to offer multiple carriers at one time, you can do that. So if somebody says, I want to offer Anthem and Kaiser and Connect for Health all at the same time, you do have the option to do that. You do have to go through the exchange. The prices are going to be the same. Not all the plans are the same. Anthem has 3 HMOs in there that are higher deductible plans, so they don't have their full portfolio and their PPO plan selections. Kaiser has been very embracing of the exchange. They have the majority of their plans in the exchange and are pretty excited about what's going on there. It's a system that really plays to Kaiser's strengths, and they like that, and they've done well with that. And then for the tax credit, you'd go to the small group exchange as well, but we'd have to enroll through the exchange. To put a small group through the exchange is a little more work than what we have now. All the employees do have to enroll online. It is more work on the employer side. So just so you're aware that if we're going to go in that direction, that it will require a little bit more work. All right, so I'm going to, and then, so kind of as we move forward here, we are going to continue to monitor all the different pieces that are going on and adapt to changes. We're going to continue to give all of our clients updates on what's going on and what's relevant. There's a lot of things that are changing, but a lot of them are not impacting our clients, so that's why we're not flooding you with updates, because a lot of it just does not impact you. A lot of the changes and deadline changes that we saw here in December that created lots of press and publicity, those were on the individual side, so we did not send out updates to our group side as well. Let's see here. So I have a couple of questions. So I'm going to run through questions. So send those in if you have those. Small groups, we can self-fund down to 10 lives on small group. We just have 2 carriers do that. Then we have a couple others that do, their minimum number are 20 and 25 employees. So that has changed here. over the last couple of months, we're seeing those numbers move around. One carrier went down to 10, another that was at 5 went up to 10, and I think we'll see that number probably stabilize around 20. And also, don't be surprised if the federal government comes out and puts a minimum number on this as well. They're not excited about a lot of our smaller groups, those under 50, moving into the self-funded market because it does avoid taxes. The larger taxes they're kind of counting on with the health bill. So don't be surprised if they put a limit on the number of like the minimum number of lives that you can self-fund for. But the self-funding is definitely saving dollars because you're avoiding the taxes. You're also able to bring health risk into that conversation again, so you health risk questionnaires. So if you have a company that's healthier than average and you're 20, 30 plus employees, self-funding can definitely make a difference and definitely worth considering. Okay, I'm going to go through a couple of questions if you guys want to send any of those in. Let's see here. So 9.5%, somebody just wanted to clarify, 9.5% is the employer number. So 9.5% for if an employer is offering an affordable plan. So it just applies to the employee. That does not apply to the spouse and kids. So it's just the employee's cost. The employee's premium, spouse and kid is not in that conversation. And then there was a question on the $2,000 for a large group, $2,000 and $3,000 penalty. So the $2,000 is if you don't offer coverage, $3,000 if you do offer coverage and it is deemed not affordable. Open enrollment. So open enrollment is for individuals. So right now we are in the first open enrollment window, and this says that you can enroll for any health plan during this window. And this is where you need to get coverage. So we need to have, if you're an individual and you do not have coverage, you do need to have a plan that you're enrolled in by the end of March 31st, 2013. If you are not enrolled by that point, a couple things happen. First, you'll then be subject to the penalty of having to pay the $95 or 1%. And then the second part of that is if you're not enrolled by March 31st, if you do not currently have health coverage, then your next date that you can enroll is January 1st of 2014. So if you don't have coverage in April, May, July, August, something happens, or you're just saying, hey, I need to get coverage, we simply cannot get a plan for you. Inside, outside the exchange, carriers are not taking new applicants because they have to be guaranteed issue, and they know that if you're outside the open enrollment, you'd be coming on for one reason, and that is simply because you have something going on that you need to get covered. And they can't underwrite, so they'd have to take you. So at this point, no carriers are offering coverage outside of the open enrollment window. The open enrollment window for next year is currently set, and this may change, currently set for November 15th to January 15th for open enrollment. That's the point where people can change plans freely and pick their plan for 2015. So what we're kind of doing is for individuals is they are picking a plan and they'll be here for a year. If they stop making their payment, the plan will term and then they won't be able to get a new plan until January of 2015. If you have a qualifying event, you do have the opportunity to pick up a plan at that point. So let's say you are at an employer and today you decide that you're going to quit, you're going to go to a different job, you're going to retire. You can do that, and you just need to, and your coverage will go to the end of the month, but you need to enroll in a plan with a February 1st effective date. And because that is, that would be there'd be no break-in coverage there. If you wait a couple months to enroll, then you're not going to have that break. You're going to have a break in coverage, and then you're not going to enroll until January 1. Let's see here. What other questions we have? So trends with employers. We are seeing employers who are moving their employees. We're seeing this nationally. If you look at unemployment figures, the majority of those being hired are being hired at part-time. And a lot of that has been employers' preparation for the requirement of 30-hour-a-week employees. So saying if you're under 30 hours a week, I do not have to offer benefits to you. The large groups, they've been able to kind of get away from this since the penalty has been delayed a year for that. So this is settling down a little bit, but by and large, we're still seeing a lot more people hired than part-time as compared to full-time. A health savings account. So we always get the question, are health savings accounts going away? The answer is no. In fact, the maximum out of pocket on all the plans, which is the $6,350, is actually tied to the maximum out of pocket on an HSA. So as the HSA maximum increases, the max out of pocket on the plans will increase, and that'll adjust every year, and so it'll move up, $50 or $100 every year. It's kind of the trend that we have seen. But HSAs, they're still alive and well. We are implementing as many HSAs as we have in the past year or two. As far as companies are still choosing them, those that are on them are still moving to them. Still a very valid option, and still with the popularity that they've always had, just because they work well for tax reasons and they're simple to use and understand. This may just be a duplicate question. If you missed the open enrollment deadline, then you cannot enroll until next year. COBRA. COBRA is still valid. State continuation is still valid as well. So if you're an employer that has less than 20 employees, you're subject to state continuation. It's a state law as compared to federal law that says if you have an employee for state continuation that has been on your plan for 6 months and they leave for any reason, you have to offer them coverage, the opportunity to stay on that plan, and just pay you the premium for the next 18 months. That is still valid. For COBRA, COBRA is just if an employee has been on your plan for 1 day. If they leave, then they are subject to COBRA, and so we still need to send out all of the notices. If anybody needs help with those, we provide those. We can get those out to you and help with any questions. We cannot complete those for you, but we can help walk you through those forms as much as we can. But those notices still do need to go out. Just as a note, no retro terms on tax, or no retro terms on employees. So if an employee is termed today, or they want to drop coverage today, we go to the end of that month. So it'd be a February 1st term date in essence. We cannot go back to January or December or November. Let's see. So that is all of the questions I have. If you have any other questions, send those over, or call me, email me, and I will definitely address those. If there's any area of healthcare reform you want to talk further about, I can definitely do that. I just wanted to kind of cover an overview here as a starting point for those conversations. I'll be in the office. My phone number here, 970-484-1250. We have recorded the webinar, so we will have that online. So that'll be available for anybody who wants to go in that, share it with their owner, share it with friends. Anybody has any questions or were unable to attend the seminar, that they'll have that. And then feel free, after you've viewed that, to call or email me with those questions moving forward. And this is the information we have as of today. This is all subject to change and is kind of changing and being more defined on a regular basis. My email, if that helps you, is tim@sageba.com. So tim@SAGE, B as in boy, A as in apple.com. If you have any questions, let me know. Otherwise, we'll end the call there, and I thank everybody for joining me.